All right. Hello, everybody. I'm Vivek Kulkarni. I'm the education editor for JACC. And today we're going to be having a journal club discussion of a recent article that was simultaneously published in JACC and presented at TCT, which we're very excited to talk about. I'll be co-leading the presentation with Megan Burke, who will be joining us in a little bit. And we're going to talk about PCI of native coronary artery versus saphenous vein grafting after bypass surgery. Before we get started with the actual fun stuff, just some required slides that I need to show you. This is a CME activity, and because it's a CME activity, we have to display these slides. You don't have to read them, and neither do I, but I need to have them on the screen so that we can say they're on the screen. Here's our statement of need. Here's our overall goal and our target audience, our learning objectives. These are our credit statements from various different societies, disclaimer statements from the ACC Foundation, disclosure and conflict of interest statements, as well as disclosures of the planners of this series and the faculty speaking in this series. And last slide about receiving credits. Okay, so for those who don't know, JACC Journal Club is a new thing that we've started doing with this, I guess about a year ago now, where we have live online webinar discussions of interesting papers that have been published in JACC. We have had a lot of fun doing this. Some of them have been more research papers, some of them have been guidelines, but the point of this is that we can have high-level discussions, really dive deeply into papers, and understand them a little bit better. We also have been fortunate that we, for these discussions, have not only had some of our team at JACC, but we also have had authors from the papers themselves. So that has really been a great experience, getting to talk directly to the authors about their papers. And we are excited to be able to continue doing that today with Dr. Roel Hoek, who is an author on the paper we're going to be talking about. He's the co-first author, and he's joining us live from Amsterdam, where it's 11:06 p.m. So Dr. Hoek, thank you so much for staying up late and joining us.
Yes, of course. Good afternoon, everybody. Hi.
So we'll come back to Dr. Hoek in a minute, but the orientation today's session, we're going to talk about the PROCTOR trial with Dr. Hoek, and we're going to have a chat-based Q&A. So what I would ask of all the participants is, as we're going through and as we're presenting everything, if you have any questions that you'd like to ask of our team or of Dr. Hoek, just type them into the chat. And what we'll be doing is we'll be monitoring the chat, and at the end, we'll have time set aside where we can go through those questions and discuss them with Dr. Hoek. So please go ahead and just feel free to type those in as you go. If you do end up typing in a question, please just indicate in your name if you are, where, maybe what your level of training is and where you're located, whether that's in the US or elsewhere or state, whatever you want to say. As far as disclosures, Megan and I have none. And this is the article we'll be discussing. It's PCI of native coronary artery versus saphenous vein graft after prior bypass surgery. Again, this was recently presented at TCT and simultaneously published in JACC. With that, I'll turn it over to Megan. Megan, are you there?
I think so. Can you hear me?
We can hear your audio. I think your video is not coming through, but we can hear you. So why don't you go ahead?
Okay, I apologize. I'm like on my phone and my laptop, and none of them seem to allow the video. But I've had a long day in the cath lab, so maybe it's better that you guys can't see me. Thank you, Vivek, for the introduction, and I'm really excited to be talking about this trial and to have Dr. Hoek here, because this trial, as we'll talk more about, is really, I think, guideline and practice changing. And it was a trial that, really informed how we're going to treat these patients. So I'm really excited to be talking about this. So as Vivek said, the title of this randomized control trial was PCI of native coronary artery versus saphenous vein graft after prior bypass surgery. Someone can go next. So just to give everybody a little bit of the background, and for any of the interventional cardiologists who are on the call, this won't be news to any of you, but saphenous vein grafts have high failure rates. That's probably not new to any of the cardiologists, but and those failure rates are really up to 50% within 10 years. So we know that pedicle, lima, and rema grafts tend to live a long time. Radial grafts, arterial grafts a little bit longer, and saphenous vein grafts have the highest rate of failure. This observational data that has been collected over time, and we'll go over a couple of those studies, but the observational data has really shown that there are worse outcomes following intervention on saphenous vein grafts compared with native vessel PCI. And so that has really informed the guidelines and the current practice. And so the most recent ACC AHA guidelines on intervention on post-CABG on vein grafts has a class 2A and level of evidence B recommendation that to fix or to intervene upon, I should say, the native vessel over a failed bypass graft when it is feasible. And so that is really sort of the current standard of care, and that is based on large observational data. So next. So I love the infographics that JACC does now with these large trials, because I think they really sort of hone in on the important points, and so I've used these infographics in our slides that were published with it from the trial. And so what you can see here is that the trial was done, it was multi-center, it was in 4 countries across Europe. So 14 centers total. There were 220 patients with prior CABG and significant vein graft stenoses. They were randomized in a 1-to-1 fashion to a vein graft PCI or native vessel PCI with an intention to treat design. And there was this study published the 1-year follow-up data, although the follow-up is ongoing. And then importantly, as mentioned, this is the first randomized trial that was directly comparing native vessel PCI to saphenous vein graft PCI in post-CABG patients where that vein graft has failed. And this randomized trial really is challenging the current guideline recommendations that were based, as we talked about, level of evidence B on just observational data. Good observational data, but observational data. Next.
Megan, for those of us who are not interventionalists, don't look at cath films all day, I included, so these were actually still frame shots from one of the figures from the paper, where they sort of showed what kind of patients we're looking at. The top set of images is one patient, the bottom set of images is another patient. Do you mind, Megan, just sort of explaining what we're looking at here?
Yeah, and so these are still frames of the angiograms. And one thing that I love about this trial is that, so in the main body of the study, they did show a handful of patients, but the supplemental data actually has the angiograms for all of them, which is really nice, and it really allows you to see the original data. And what you see here, so in the top patient, what we're looking at on the left frame is the native vessel. And so you can see there's a little white star that highlights this. We're looking at an obtuse marginal that is occluded here. And then on the right for that patient, you can see that there's a vein graft that is going to that obtuse marginal branch. And you can see there's a focal stenosis in the proximal vein graft there. And so what we're looking at here, as well as in the second patient, that both of these patients had chronic total occlusions of the vessel. So you can see in that second patient as well. So the first patient had an obtuse marginal that was occluded. The second patient has a chronic total occlusion of the right coronary artery that's occluded proximally, and this had been grafted. And you can see the vein graft there on the right, and there's a focal lesion in that vein graft. So there's, we'll talk a little bit more about the types of both native lesions that were intervened upon, as well as the vein graft lesions and the characteristics, because that really is important here in interpreting the results of the trial.
One question for Dr. Hoek before we move on to the actual trial details. I'm not an interventionalist, but I found this extremely helpful that every single patient's angiogram was included in
Yeah.
the supplemental figures.
Amazing.
I'm just curious from the standpoint of designing this trial and reporting on this trial, how you guys decided to do that. I think that would be a great standard to set for interventional trials if that could be possible. I'm just curious to hear more about that story.
Yeah, it's a good question, and it gives a little bit of the background of when we created this paper. I do also really like that all the angiograms are indeed in the supplementals. I do not very happily think back of the 40 straight hours that we had to put into creating these figures because it was quite an extensive job to do so. But there has been actually one trial, the Orbita trial, which has done so, and that gave us the idea, and also it was also opted by JACC itself that it could aid to more information if we just have shown all data, because I think we will touch upon later. There are some factors in the in and exclusion criteria by which the interventional cardiologists were thinking that it might be beneficial to see exactly what kind of lesions were included and to provide full transparency to the data.
Yeah, well,
Yeah.
thank
We
you
always
for
want to see
taking
primary data.
the 40 hours to do that. I really appreciate
Yeah.
it.
And interventional cardiologists, we always want to see the primary data, right? I mean, a report can only tell you so much, but the pictures tell you everything. So to continue with the trial design, the primary endpoint was MACE, and that included all-cause mortality, clinically driven target coronary territory revascularization, excuse me. So the revascularization of a specific territory that a coronary or bypass graft feeds. And then thirdly, the non-fatal target territory myocardial infarction. And this was a composite endpoint. This demonstrates the trial profile and how patients were enrolled. So you can see there were 341 patients that were assessed for eligibility. Importantly, many patients were not eligible. So you can see here 121 were not eligible, 26 didn't even meet the inclusion criteria, and then 95 met the exclusion criteria. 220 patients were ultimately enrolled, and then you can see they were randomly assigned to PCI of the native vessel or the vein graft. And then it is important to talk about the fact that there was an intention to treat trial design, but 12 patients crossed over from the native vessel PCI to vein graft PCI intervention. And in the other arm, there were 3 crossovers. Fortunately, no one was lost to follow-up or withdrew consent, and you can see there the final numbers.
Dr. Hoek, I was wondering here if you could give us a little bit of insight in 2 things. Number one, what was if you could remember, tell us what was the reason that these patients were excluded? I mean, that's a pretty significant amount. The study does list exclusion criteria. Some of them are clinical, some of them are angiographic. What mainly were the reasons?
Yeah, no, that's a very good question. I do remember, and in fact, it's in the supplementals. We have indicated this per reason, how many patients per exclusion reason were excluded. So the majority, 50 or 41%, was just very easily by failure to provide informed consent, which is an exclusion criteria you cannot overcome, I think. And there were also quite some patients that had a graft, a stenosis in the graft. Well, they had an ACS, a non-STEMI, but they were not easily being managed to be pain-free, and they had to have like this emergency PCI. And that's the thing of this study. You're randomizing between mostly a CTO procedure and which is quite complex, and it takes a lot of time, and also some logistic preparation. And on the other hand, relatively easy and relatively quick PCI of the vein graft. So yeah, in some cases, 21 to be complete, we did not have the time to randomize, and we had to exclude those patients as well. And
Yeah,
then
and I
there's
think
some small.
No, I'm sorry, I
There's
didn't
some
mean to.
some small numbers on the other exclusion criteria, but those are just applicable.
Yeah, and I think it's worth highlighting that the most important inclusion criteria for this trial, and I don't think the trial would have worked without it, because how can you randomize if you don't do this? But both lesions had to be intervenable, right? So you couldn't enroll a patient where you could fix the native vessel PCI, but not the vein graft, or vice versa, because otherwise there would not be equipoise here. So
Yeah, exactly.
And while we're on it, there was if you could talk a little bit more about the crossover patients and what happened to those people, why did they have to cross over?
Yeah, in total we had 15 crossovers, 12 from the native vessel PCI to the vein graft PCI, and 3 the other way around. The main reasons why they were crossing over is because the procedure of the attempt to open the native vessel failed. In some cases, they performed when the first attempt failed, they performed a reattempt. On the top of my head, I think in 5 or 6 cases they performed a reattempt, and in 4 of them they failed again, and they had to cross over as well. And for the 3 that went the opposite direction, in all honesty, those were not in our sites. I don't know exactly why they performed the crossover from saphenous vein graft to native. Those 3, yeah, I can't recall, to be honest.
So it's important to highlight, and we've sort of already gotten into this a little bit, but one thing that is really important to know about this trial is understanding chronic total occlusions and how interventions on chronic total occlusions are different than a run-of-the-mill PCI. And so what I want to highlight here, the angiographic characteristics were similar in large part between the native vessel and the vein graft, but I do want to highlight the fact that there was a very high number of chronic total occlusions of the native vessel in both arms. And so you can see there that it was 90 in both. I'm sorry, 90% in both. And then you can see the numbers there, 83 in the one arm and 80 in the other. And that is a high number of chronic total occlusions. That is much higher than what was seen in the observational data. And so that certainly could be one reason why the outcomes of this study look different. And it's worth saying that in general, when we're intervening on chronic total occlusion, so there are not all interventionalists can do chronic total occlusion interventions. It's also important, it requires a special skill set. It is much higher risk. And it's also important to note that the failure rate, or I should say, or the rate of success is different than the success rates of PCI in general. So when we talk about high volume CTO operators, the success rates of CTO PCI is in the 70 to 80% range. And so that is what this was seen in this trial, which also speaks to the fact that the operators in this trial were highly skilled. But so it's not surprising that there were 12 patients that had to cross over from the native vessel PCI group, because it's pretty consistent with the rate of failure, especially first time CTO intervention. But that is a really important and notable factor in the angiographic characteristics in both groups.
Yeah, it's also notable to me that whether we're talking about the native lesion or the vein graft lesion, that the median diameter stenosis was above 90%. I mean, these are very, very obvious and significant lesions, which is not always what we see clinically.
Right. Yeah. And the inclusion criteria said it had to be at least 50%, which is an intermediate lesion, but these lesions were clearly severe.
So we just have a quick poll for the audience, since most of what we're going to be talking about involves CTOs. Does your institution have high volume CTO operators? We'll open the poll up for a little bit and let you guys weigh in. And I would venture a guess that if you're not sure, the answer is probably no. Unfortunately, not a ton of centers do have high volume CTO operators, at least not in the United States. We'll take maybe another 30 seconds or so and let people answer that. While people are filling that out, Megan, is there a certain standard in the interventional community about how many CTOs you have to do to count as high volume?
Not to my knowledge. I feel like it is a tight knit community, the CTO community. There is no accredited training for CTO specific skill set. However, there are a handful of CTO fellowships, or also known as CHIP fellowships, in the United States. I can't speak for Europe, but there are a handful of well-known CTO operators who pioneered the field across the US and also in Europe and specifically in Asia as well. In Japan, there are a handful of pioneers in the CTO space. But generally speaking, people who are skilled as CTOs have trained at or with one of those operators and or are at a program or institution that has a CHIP fellowship. So it is expanding, but to my knowledge, there is currently no clear criteria for how many or what types of CTO interventions you have to do to be skilled. And I will say there is a wide range of difficulty when it comes to CTO interventions, and that is determined by the JCTO score, which is mentioned in the trial.
So on our poll here, if we forget about the percentage that didn't answer, it looks like it's about 2-to-1 people who generally most centers do not have high volume CTO operators. So I think, Dr. Hoek, when we're thinking about the results of the trial, which will be coming up, Megan mentioned already that a key inclusion criterion was that it was felt to be equally technically feasible to do either vessel. But that depends a little bit on who the operator is. And if your operator is a person who's very comfortable with CTOs, they may feel like there is technical equipoise. But if it's a person who's not comfortable with CTOs, they may feel like there is not technical equipoise. I'm curious, what's your understanding of how that will affect our interpretation, and how did that play into when you guys were doing your trial?
Yeah, that's a good question indeed. In Europe, we do have quite some experienced CTO operators. In our institution, in the Amsterdam University Medical Center, we have at least 3 well-trained CTO operators, and more younger to become. The PI of this study, Professor Paul Knape, he was quite selective in sites that could participate in PROCTOR. Paul had to know the PIs of the other sites and had to know their skill set. So in terms of the study, the interventional cardiologists that were conducting these or performing these PCIs were highly trained, and as such, most cases, or the cases, there were a lot of cases that were for them technically equiposed. To answer your question on how this would affect the overall clinical care, I think maybe we can better answer that question when we first have the results of the final outcome. Otherwise, I might give away some of the
Let's
results.
go ahead and keep going.
So this is looking at the procedural characteristics. So for those, again, who are unfamiliar with CTO interventions, what you see here is in the top is how the patient was treated. And so, as mentioned, the success rate was high for the CTO intervention, suggesting that these were skilled operators. And then they do talk about what the final CTO crossing technique. So this is probably unnecessarily technical for the purposes of the discussion, but AWE stands for anterograde wire escalation. That's generally the lowest technical difficulty required for C2 interventions. Antegrade dissection and reentry, where you dissect the vessel and reenter it. It's a little more complicated. And then the retrograde approaches, retrograde wire escalation and retrograde dissection and reentry. So you can see here that it sort of ranged the techniques that were required, but a CT, you do have to be a highly skilled operator to be able to do retrograde dissection and reentry, and that was a not insignificant portion of patients. And then I also wanted to talk about, we've been talking a lot about the native vessel techniques, but I think it's important to note that in the vein graft interventions, there was a there was a high percentage of embolic protection device used. And so that, that is something to note, because the use of embolic protection device in vein grafts is controversial, but many operators still do use that. So that was something I wanted to point out. And then again, noting that there was a high success rate in the interventions that were done. And these are complicated interventions, both from a native vessel and vein graft standpoint. And so the success rates may not be as high with less skilled operators. And then I also wanted to point out the characteristics and the differences in both groups between stent length and contrast use specifically. So it's not surprising, given the CTO lesions, which can often be long lesions requiring a lot of stents, that there was increased stent length in the native vessel group. Increased stent length is correlated with failure of intervention or the need to revascularize. So that is one aspect that could be driving the endpoints that we're seeing. And then one of the secondary endpoints that were looked at was renal failure. And so contrast use and the amount of contrast use was certainly different in both groups. Unsurprisingly, more contrast was used in the native vessel PCI group. So looking at these results, the composite endpoint, you can see 34% in the native vessel PCI compared with 19% in the vein graft PCI. There was no statistically significant difference in all-cause mortality in this one-year follow-up. PCI-related MI specifically, as well as repeat revascularization, are the two outcomes that drove the primary outcome. And so you can see 13% compared to 1% for PCI-related MI in the native vessel versus vein graft, and then repeat revascularization was 18% compared to 9% in the native vessel versus vein graft. And again, not terribly surprising, the rates of periprocedural MI are higher in CTO PCI compared to standard PCI. So not something that was terribly surprising. So you can see here just the Kaplan-Meier curves, which really just is a different way of looking at the results that were already mentioned. And importantly, you note that the curves separate early. The early separation is, not surprisingly, again, due to the higher rates of periprocedural MI. And then here, these are the two outcomes that drove that composite endpoint. And again, on the right, you see target coronary territory MI, early separation of the two curves. But again, even for target coronary territory revascularization, you see over time that those curves also separate with lower rates in the vein graft group. Okay, and then this is again just looking at the endpoints when it comes to intention to treat. You can see some of the other endpoints that were looked at, including not just territory, but specifically the revascularization of that target lesion and the failure rate. So revascularization and failure rates were higher in the native vessel PCI group. Again, this may speak to the fact that so many of these lesions were CTOs. And importantly and interestingly, there were no events of renal failure in either group, which is good. Again, skilled operators and at highly skilled centers, but it would also, I think, speaks to the fact that the numbers in the trial were a little bit lower than originally anticipated. So probably underpowered for that endpoint. and I'd love to hear, Dr. Hoek, what your thoughts are, because I think renal failure is an important outcome to look at, but may not have been able to really be assessed with the numbers in the trial.
Yes, I think first of all, thank you for this overview. I think it is important to note that we chose to define renal failure requiring replacement therapy, and that is quite, so to say, extreme renal failure for those patients requiring dialysis, etc. If you would take a look at other trials, some trials chose to apply a more liberal cutoff. For example, glomerular filtration rate below 30%. We chose to do the cutoff of replacement therapy, and it was not observed. Maybe indeed, if we would have reached the initially intended sample size, then we would have seen some renal failures, but I'm not sure if that would ever reach any significance if it's both zero in both groups with 220 patients.
Yeah, Dr. Hoek, one thing we haven't talked about so far actually is that when you guys were designing the trial, I think you had intended a sample size that was much higher, like almost 600, 580 something patients. And then in reality only ended up getting, a little over 200. Can you talk a little bit about your difficulties in enrolling patients and what do you think made it that you had a hard time with that?
Yeah, that was indeed difficult. We have finished at 220 of the 584 patients. We were prematurely ended, mostly due to financial restraints, because the enrollment was way slower than it anticipated. We have some excuses for it, so to say. Of course, COVID is a known one. We had a lot of difficulty with Brexit as well. This trial was just drafted after Brexit, but that made all legal restraints within the United Kingdom very difficult. And the United Kingdom was supposed to be a country with a lot of enrollment, and unfortunately, finally only ended up in a total of 16 or 17 patients. So that was a setback. And also, I think the logistics behind this trial were that difficult that not all sites just had the logistics to manage these trials and to actively include all patients that was presenting. As we see, we had 120 patients lost to that could have been included. That's almost half of it's more than half of our actually included number. But even if we would have included all those 120 patients, we'd still not have reached our sample size. So, meaning that the patient group itself is also difficult to find.
Thank you. Yeah, and it's interesting that even with those difficulties in enrollment and even with a smaller sample size, you still were able to detect significant differences in the most meaningful outcomes. Maybe not in some of the more secondary ones, but in the most meaningful ones, still we're able to see a big difference. One other thing I was just hoping you could comment on is the decision to include as part of your outcome PCI related MI. And I think that has been controversial in various trials over the years of how to include that and what you're measuring and what you should or should not include and after what time period. If you could just talk a little bit about your decision making for that endpoint.
Yeah, sure. Indeed, it is debatable, so to say. I want to note that we used very high cutoffs to define PCR related MI. So it's the sky definition, meaning that the troponin levels have to be more than 70 times elevated as compared to a pre-procedural, or the CKMB levels had to be more than 10 times higher than pre-procedural. So these MIs that are included are really severe MIs with large troponin or large enzyme releases. And there has been studies that show that these MIs with these kind of enzyme releases have a poor result on your prognosis. And we have also to acknowledge that indeed you are randomizing between a CTO procedure mostly and a vein graft procedure. So we felt it was most honest to include this endpoint. Also because we also, to be honest, anticipated that vein graft PCI would have had more PCI-related MIs as well. In the literature, also where this sample size was based upon, a vein graft PCI often leads to no reflow or distal embolization, which could also lead to periprocedural MIs. But that phenomenon was rarely observed within our results. So I think that's also a very important thing to note, that not only native vessel PCI had a high event rate, but vein graft PCI actually had also a way lower event rate than anticipated.
Yeah, I agree. That is not consistent with general practice. So I think, we can all agree, the major takeaway from this trial that, again, was, I think, unexpected for many of us. I think probably including for those who ran and designed the trial. Dr. Hope can correct me if I'm wrong, especially because originally it was designed as a superiority trial. But what this is why we do randomized trials. That what they found was that vein graft PCI compared to native vessel PCI was associated with better 1-year outcomes and fewer major adverse cardiac events. And so, to talk about some of the limitations of the study, which I have to say, we always talk about the limitations of every study, but this study, Dr. Hoke, you and your colleagues really have to be commended. This is such a difficult trial to do for so many reasons, some of which you've already highlighted. But to do this study in the way that you did it and in the rigorous way that you did it, specifically making sure that there was equipoise between the two arms, is really important, and this study was needed. And so we'll take these limitations with a grain of salt, but the study was randomized but unblinded. It was going to be really difficult to blind both the operators and the patients. The outcomes beyond 1 year still remain unknown, so it'll be really interesting to see the longer follow-up data from the trial. As we've already talked about, the study was not as large as originally intended, and so certainly for some of these outcomes, especially the secondary outcomes, may have been underpowered. One limitation that we haven't talked about, but the authors mentioned when they discussed the limitations, is that there was no arm for medical therapy alone, and so many of these patients are managed medically, and this trial compared head-to-head intervention without looking at comparison with medical therapy. And then I think, it's not surprisingly, for many of the reasons we've talked about, most notably because of the population of operators at these centers, the results may not be generalizable to all centers and all practicing interventional cardiologists, especially looking at the poll results where 40% of you are saying that you don't have a CTO operator, right? So that is going to look very different. And so it's definitely something to think about.
And I think this is, if I may real short make one comment, I think this is a good moment to answer the earlier question that was asked me on indeed these equipoise between technicality for non-CTO centers. I think indeed the fact that vein graft PCI shows relatively more safe than we anticipated may also be how do you say, a comforting message for interventional cardiologists that are not experienced in CTO PCI. So they can, for example, if a patient with SVG stenosis presents and they don't have the skill set to perform CTO PCI, they don't necessarily, based on this data at least, have to refer to a third center to perform a CTO PCI, but they can perform the SVG PCI themselves. So I think that it's not generalizable, but in that way, it is generalizable to the centers without CTO operators, in my opinion.
Absolutely. It makes it not generalizable, but it also, I think, better informs the day-to-day practice of interventionalists and cardiologists who are taking care of these patients. Absolutely agree.
Yeah, if anything, it's almost that, if this study supports preferentially intervening on vein grafts, which tend not to be chronically occluded in the way that native vessels are, it almost means that whether you have a CTO operator or not, you can still treat these patients appropriately by intervening primarily on vein grafts.
Yes. Yes. That's exactly right. This is why this trial is really, maybe even more practice changing than most, which is the last and most important point here. But I think, this trial, I think, for interventionalists who are doing these interventions and thinking about vein graft versus native vessel interventions, I think many of us were surprised, right? It was the first randomized trial, and it contradicted the current observational data. And that it's large observational data. So there's the data that informed the guidelines are based on a meta-analysis of 40,000 patients, 22 studies, and importantly, one of those studies that was run by Mas Berlakis, who's actually probably one of, if not the foremost CTO operator in the United States, showed that native vessel PCI went out, and this study contradicts that. So I think two things are driving that in this study, and the first is the importance of the heart team approach. And the heart team approach, I think, is essential in most of what we do, especially when we're talking about interventions for patients. But the patients in this trial, and Dr. Hoek, correct me if I'm wrong, the evaluation of these lesions, the decision about whether there's equipoise for intervening on both the native vessel and the vein graft was done with a heart team approach. Is that fair to say?
Yes. So the heart team had to define that there was indication for revascularization and not for medical treatment, and then the heart team, including the CTO expert, the CTO operators had to define if both lesions were deemed technically feasible.
Yeah. So I think that was a really important piece of that drove the results in this trial. And secondly, the importance of the lesion characteristics. And we've already talked about this, the difference in the type of lesions in this trial compared with the observational studies. What I think was not surprising is that the group of patients with CTO-PCI had higher rates of periprocedural MI, because we already know that this is true about CTO-PCI compared with standard non-CTO-PCI. And then I think lastly, what was somewhat surprising, but maybe not, was that repeat revascularization was higher in the native vessel group. I think, those of us who do CTOs, like myself, are big believers in the fact that that native vessel PCI is durable, and that traditionally we've thought of vein graft interventions as being less durable. But this was not the case in this trial, and I think that is really interesting. And then, as we've already said, for many reasons, there are takeaways from this trial that should and will inform our practice when it comes to approaching these patients and the technical approach for these patients. And very likely this will be guideline changing because now we have a randomized control trial that contradicts the current guidelines, and that will bring up the level of evidence for the new recommendations when they come out.
Great. So what we'll do now is I have one question, but as we're doing that, if you guys haven't already done so, please type your questions into the chat. We've seen a few. Put in your name, training level, position, state, country, whatever you want to put in there. But now's the time to put in your questions so we can gather them if you haven't already. While we're waiting for questions to come in, Megan, I have one question for you as a practicing interventionalist. So I think from this trial, it's pretty clear that if you come across a patient like this who has a CTO of a native vessel and a vein graft that it looks intervenable, it makes sense to maybe go after the vein graft, and we have more support to do that. I'm curious, what in a situation where the native vessel is not a CTO, and where the native vessel PCI looks like it would be relatively straightforward without the same CTO techniques, does this trial still make you think about intervening on the vein graft preferentially, or is that a little harder to say?
I think it's a little harder to say, and I think mainly for the reason that Dr. Hook mentioned, which is that the rates of complications and peri-procedural MI were lower that in this trial than expected. So when we think about the risks of intervening on a vein graft, as Dr. Hook mentioned, no reflow is common, right? That vein grafts are veins. They are not arteries. They behave differently. Plaque develops differently. When plaque does develop, it has a high risk of embolizing distally. That's why these embolic protection wires exist. And so the concerns about no reflow and some of the other technical challenges that I won't bore everyone with do still weigh in, and I think that if a native vessel lesion is much more straightforward, then I may think about it differently. And just to say too, the selection of, as Dr. Hook mentioned, the selection of the vein graft lesions were less complex too. They excluded vein grafts that had aneurysms, which are common. Excluded. There were heavy levels of thrombus, which can be an issue in treating vein grafts and makes distal embolization and no reflow much higher risk. So those exclusion characteristics in the vein grafts, plus the technical characteristics of the native vessel PCI, I think do have to weigh in. And that's where the real world patients may not match the patients in this trial.
And Dr. Hoke, if you wouldn't mind, can we learn anything from the patients in the native vessel group who did not have CTOs? That's only a minority, so that's not going to be a ton of patients in this trial. But can we learn anything from their interventions or their outcomes?
And we do have sub-analyses exploring the presence of a native vessel CTO, and in that sub-analysis, the hazard ratio is numerically still favoring the vein graft PCI, but we have to say that the absolute event rate is only 8 versus 5, so 8 in the native and 5 in the vein graft group, which is of course not significant, and that can be due to underpowerment, or it can also be due to the fact that indeed in these groups there's no difference in absolute numbers.
I
think what
No, I'm sorry, I didn't mean to interrupt.
I think it is indeed that fair based on this data. We're not saying that everybody should do vein graft PCI, definitely not. If the native vessel looks relatively easy, not complex to do, or subtotal lesion maybe, which can just be performed antegrately, then we're not against that. Definitely not. I think this trial just more shows that it's also not as bad as we thought to perform the vein graft PCI, and more complex than native lesions.
Megan, you can go ahead.
Oh, I was just curious for Dr. Hoke what the thoughts are among the trialists for you and the other trialists about what the long-term follow-up is going to look like. Because I did think to myself when this trial came out, thinking about the early CABG versus PCI data, and that over time the intervention arms crossed. And so, what was seen in the early follow-up didn't end up holding true long term. And I wonder if that's something that we might see in this study, and what you and the other trialists think might happen in the long-term follow-up.
Yeah, that's the, I'm wondering as well every day. So we initially thought that native vessel would be better. That's why that's you can also see in the fact that we drafted it as a superiority trial for native vessel over vein graft. We did not anticipate this large difference at 1 year. Definitely not. So this is surprising. Normally, I would say that yes, there might be a chance that the lines will cross indeed, and that native vessel will become equal or better at 3 years follow-up. That was what we would have thought from the beginning, that there might have been at the beginning some more PCR related mice in the native vessel, but over time those lines would cross and a native vessel would be superior to vein graft PCR. However, we also we didn't expect this result, so I'm not sure anymore what to believe, in all honesty, because I can believe the lines will cross, but then I might be wrong again. So yeah, I'm just really curious. I think it can go both ways.
Yeah, I
Dr.
think
Hope,
it's
I'm sorry, Megan.
no,
We have only a few minutes left,
oh,
so I just wanted
right.
to draw attention to a couple of questions in the chat that came up. One was if you could talk about embolization of vein grafts in the cases where the native vessel was intervened on.
Yeah, you mean closure of the vein
Closure,
grafts?
yes, sorry. Closure of the
Yeah,
vein graft by one method or another when the
yeah.
native vessel was the one intervened.
It was allowed. Top of my head, it happened in not that many cases. I think maybe 2 or 3 cases. It was discretion of the operator. At the Amsterdam UMC, we're not fan of doing it because it takes away your retrograde option. You can saw in the earlier tables that we had 50% retrograde dissection and re-entry method, but you have to realize that when there's a vein graft, the retrograde option is relatively easy because the retrograde access is already there through the graft. By coiling that, you would lose your retrograde option for a possible reattempt or in case of a restenosis. So we were not a fan of doing it, but it was allowed, and some operators did it, but only maximum 5 patients, I believe.
Okay, great. And it's also interesting. These lesions are very high grade. 90+% angiographic stenoses. So, I don't know how much the importance is of that competitive flow when you have such a tight lesion like that on one
Okay.
side.
Yeah.
And then one other question. We don't have time for a lot, but one other question is: were there any important subgroup differences that you guys were able to identify by age or lesion location, presence of diabetes, any other important comorbidities that would make it maybe more favorable to do one approach or the other?
So we looked at age, sex, diabetes, the presence of a CTO, the presence of an ACS or prior PCI in the grafting. None of them were significantly different. That can be also because of possible underempowerment. I think it is interesting to realize that for patients with an acute coronary syndrome, presenting with acute coronary syndrome, that also the patients that did have an acute coronary syndrome had a significant hazard ratio, where you might think that patients with stable disease are in stable disease, the events will not occur that often, and in acute coronary syndromes, the patients will have more repeat events in the graft arm, but that was not the case. So I think that's an interesting that also in the ACS patients you can do safely SVG PCI. That was an interesting one we found, and furthermore, yeah, we took a look at all the variables I just mentioned, but there was no significant findings in these subgroups.
That's great. Thank you very much, Dr. Hoek. So that's going to take us to the end of our time. But I just wanted to first of all say congratulations, Dr. Hoek, on a trial very well done. I think we all learned a lot from this trial, and I'm going to be expecting angiograms in detail from every interventional trial from now on. And thank you, Megan, for putting that together. And thank you, Megan, for your help with the presentation. Dr. Hoek, thank you for being here. I know it's just turning midnight in Amsterdam, so I really appreciate that. And for the audience, this, like we said at the beginning, this is a CME accredited activity. So if you would like to claim CME credit, their instructions are available for how to do that. There'll be a recording posted of this webinar on the website, which you will be able to access as you like. And keep your eyes open for emails about another session about a trial published at AHA. We have one coming up in a couple weeks, and we'll be advertising that soon. So again, thank you, Dr. Hoek, for being here. Thank you, everybody, for your time. Have a good night, everyone.
Thank you for having me. Bye-bye.